Our next speaker is Dr. Murray Kwan from the Division of Cardiothoracic Surgery at UCLA, and he'll be talking about mechanical support, the role of VAD versus total artificial heart.
Morning, everybody. My name is Murray Kwan. I'm one of the heart surgeons at UCLA, and today we'll be discussing the role of mechanical circulatory support with regards to ventricular assist devices, or VADs, or the total artificial heart. So we'll start with the definition. The definition of mechanical circulatory support, or MCS, is a device that either assists or replaces the left, right, or both ventricles of the heart to help pump blood. And unbeknownst to some, the intra-aortic balloon pump is considered a mechanical support device, as is ECMO. Most people think of VADs, or ventricular assist devices, of which currently there are two iterations. One is a volume displacement pump, and the other is a continuous flow pump. And we'll discuss both of the nuances of these, and then the artificial heart as well. So when you think of heart failure, it's helpful to think of it as a continuum of a disease. So at the initial stages, when symptoms are very minor or mild, all that's often required is risk factor modifications, get more exercise, eat a better diet, etc. But as you march up the staircase, then you start to see the interventions increase, starting with medical therapy and then things like ICD or pacemakers. And then once the symptoms get what we call refractory, at the top of the staircase is when you start to think about MCS and transplant as well. The definition of refractory heart failure, though, has not ever really been clearly laid out. There's no consensus definition. So what we attempt to do in the industry is to look at certain objective criteria to help us identify which patients would be amenable to MCS therapy. So for example, we use the peak oxygen consumption. Anything less than a VO2 max of 14 peaks our interest in this patient population. Sometimes we will utilize various scoring mechanisms like the heart failure survival score, which takes an amalgam of things like coronary disease, intraventricular conduction delays, the patient's ejection fraction, and attributes a score, and then you get sort of a one-year survival risk assessment. And that'll kind of tell you how sick these patients are. INTERMAX is a very commonly used criteria that we now use in MCS therapy. And what it is it's basically the National Heart and Lung Blood Institute of the NIH, along with CMS and the FDA, have created a registry or a national database which we compile information on these patients. And we basically have 7 classes or criteria here. So you can see at the bottom, these are New York Heart Association Class 3 patients, but require no therapy would be a INTERMAX 7. We don't think about them at all. When you start thinking about a device, however, is when you get into the top stages, the first 1, 2, and in some cases the INTERMAX Class 3. And essentially these INTERMAX 1 and 2 are patients who are basically impending death, either within hours or days if some sort of escalation of therapy is not instituted. So it's important to know what indications we're using devices for. In the temporary indications, they are bridge to transplant, so we're trying to get these patients to where they can be transplanted. Bridge to recovery, their own native heart may recover, or just a bridge to decision. So sometimes we get a patient, we don't know much about them, and you have to sort of clarify what their social situation is, what their neurologic status is. In the intervening time, a device is often helpful to help manage them until they're ready for a decision. And then the permanent form is destination therapy. That is the MCS will be their enduring therapy for the remainder of their natural lives. And these are patients who are not transplant candidates. So someone who falls out of our normal age criteria, for example, or if someone has HIV or hepatitis C, those are not patients that we are currently transplanting. So there are multiple factors that go into deciding who is an MCS candidate, and there are both cardiovascular things to think about and non-cardiovascular, the yellow on there. So let me just give you a few examples of how we kind of think about this. On the non-cardiovascular side, obviously things like their other organ function, their liver function, pulmonary function, all come into play and influence our assessment of their candidacy. advanced or age, the body size. If a patient is at the extremes of body size, some devices need to be implanted, so they wouldn't qualify. They're not large enough, or we would have to go to an extracorporeal or outside the body type model. Cancers, nutritional status, all these also obviously factor into our decision process. On the cardiovascular side, the blue side, you're looking at things like what would impact how we use a device in there. So if they have an intracardiac shunt like a PFO, those are things that we have to close at the time of MCS implantation. Certain valvular diseases need to be addressed. I won't go into all the nuances of why, but mitral regurgitation and aortic stenosis in general are well tolerated. We don't need to address those in our patients. But mitral stenosis and aortic insufficiency, on the other hand, need to be addressed at the time of the NCS implantation. So those are things that we kind of consider as we're trying to come up with the best plan for these patients. So obviously, as you're hearing multiple times today, heart failure is very prevalent in our society and occurs, about 500,000 new cases each year. But transplants has remained static over time at about 2,000 a year. And most people, realize that's a donor limitation issue. So we're clearly not able to fully meet the needs of our patient population. So over the next few slides, I want to show you how devices have impacted our transplant. This is a very busy slide, but I want you to just pay attention to two lines in particular. One is the purple, the sort of purple line, I don't know what color that, which is inotropes, and the other is, what is that, yellow, green? The LVAD. So as you can see over this intervening time between 1998 and 2002, inotrope usage has declined. These are how the patients present for OHT, by the way. So patients presenting with IV inotropes, you're looking at around 2/3 of the patients back in 1998 has declined to about 38%. And then on the flip side, LVADs, and here this has been around a while, but they were only charting it since the mid-2000s, has gone up from about 20% or so up to about 38%. These are very intertwined, right? One impacts the other. So the fact that I think that many of the patients who previously would have been managed with just IV inotropes are now being managed with MCS, much more elegantly, I might add. And these are patients who are coming in from home oftentimes, as opposed to in the unit with the Swan-Ganz catheter and multiple drips. So this is one way that MCS has impacted how patients are showing up for transplant. Another thing that I think it has an impact is on the wait time. So median wait times has increased over the last 10 years or so, but it hasn't been uniform across the board. So it depends upon what your status situation is. So the largest increase in time was actually for our status 2 patients, with about a 9.3 month increase in wait time. And you can see the average there is about 20 months for the status 2 patient, almost 2 years. Status 1B had only a 3.5 month increase, and status 1A had a 0.7 month increase. And in fact, the median wait time for patients with devices versus those without is about a month shorter. What I think is happening here is that these patients who are getting devices, they get 1 month of status 1A listing time. Those patients are usurping much of the heart transplants that are coming through, so that the patients who are left with status 2 are waiting longer. And I think that dynamic is definitely at role here in showing how the wait times have increased. Most importantly, I think, is deaths on the wait list. So if you look at the bottom line, if you look at the top line, you see for each age criteria, you can see that death on the wait list has decreased over this interval time. And I think one of the most important factors in that is our death on the waiting list while having a device that's in the lower part has declined as well. Okay. So here are the MCS options we'll be discussing. On the VAD side, there's the pericorporal VAD, which is really our workhorse for the better part of 2 decades, the HeartMate 2 axial flow pump, the CentraMag centrifugal pump, the newly FDA-approved HeartWare HVAD, and then for the artificial heart side, the SynCardia artificial heart. So with regards to the PVAD, the pulsatile pump, again, this is what we use for the better part of 20 years. you have basically a mid to early level support system that can support the left, right, or both ventricles. It's pneumatically driven, and it's actually two pumps that hang outside of the body, so it's what we call pericorporal or extracorporal. It does require anticoagulation to an INR of about 2 to 3, and because it's implanted outside the body, we can use it in our smaller patient populations, those with a BSA of at least 0.7 or greater. This is kind of an interesting slide. So on the top, what you'll see is an EKG tracing. This patient is in coarse V-fib. We don't typically attribute this to a perfusing rhythm. But what you'll see on the bottom is their arterial line tracing. So this patient is in V-fib. They have biventricular pericorporal devices in, and this pulsatility is being provided for by the devices themselves. So, this was the kind of the refrigerator that is the console for this device. It stands about 4 feet tall, and it obviously does not lend itself to patient mobility. What really sort of transformed this was the newer consoles that have come out that are obviously much more portable, the TLC2. These patients are going home. So right now, we are, across the board, about 89% of patients are actually being discharged at home with this type of portable console. And on average, they spend 83% of their waitlist time outside the hospital, so at home with family, as opposed to, again, in the unit. So that was sort of one of the revolutionary things. It's not just the devices, it's a lot of times it's things like this that really revolutionize our care. UCLA has probably one of the most robust PVAD experiences around the world, actually. We used a lot of them. And what this shows is basically our bridge to transplant rate in the green is about 68%. The red line just shows who's supportive of devices. The black line is deaths, so all three of these lines have to add up to 100. Our median wait time was around 98 days, I believe. 98 days. It was the median time to transplant. Okay. So the next device is the HeartMate 2 axial flow. This works very differently. This is a continuous rotary flow pump. So there is no pulsatility afforded by this device. It is a mean arterial pressure. So just to give you a stark example, I had a patient who had a HeartMate 2 in. They were in the cafeteria. Before they ate, they actually got hypoglycemic enough that they had a syncopal episode. A well-intentioned bystander did not feel a pulse and initiated CPR, although the patient was actually very much, with it once they got a little sugar on board. So, that's just an example of what you'll never find a pulse on these patients. Or I shouldn't say never. I mean, if the device is working to full flow, you often will not find a pulse. If the device is not, and we're allowing the heart to eject a little bit, you may feel a very weak pulse. But by and large, just think of it as you'll feel a mean arterial pressure. The aortic valve, because you're providing full flow, may or may not be opening. In some cases, it's actually just sclerosis shut. There is still a drive line. This is not like the pericorporal device. It doesn't hang outside the body. It's by and large implanted, but there is still the Achilles heel of these devices are you still have a little drive line that hangs outside the body. And we still anticoagulate these patients. So again, this is the device. This part here is the actual pump. And you can see in it, there's the rotary flow. I don't want to. And the inflow goes through the LV apex, and the outflow goes to the ascending aorta. It's valveless. It has only one moving part, so it's projected to last a long, long, long time. And right now, I would say it's our device of choice for patients who are going to be bridge to transplant with a LVAD-only strategy. But that may change. It was FDA approved for transplantation in 2008 as a bridge to transplant and as a destination. So it's the only currently available destination therapy device that's FDA approved, and that was in 2010. And in looking at 169 patients, their survival at 6 months and 1 year was 90 and 86%, with about a third of them being transplanted. This is across the country data. So about 14 to 20% of patients will require some sort of temporary right-sided support when you put an LVAD in. And so currently what we will use is a Centromag centrifugal pump. This is extracorporeal. We don't implant this entire thing. It's outside the body, but it's routed such that it diverts blood away from the right atrium spins it through the centrifugal pump and delivers it back to the pulmonary artery. And typically, I would say, it's helpful we support these patients for 1, maybe 2 weeks while their RV recovers, at which point we remove it, and then continuing them on with a HeartMate 2 LVAD bridge transplant strategy. Like consumer electronics, as things evolve, they tend to get smaller. So this is the latest FDA-approved device. It's made by a company called Heartware, called the HVAD. And you can see it's about the size of a D battery. It's fully implantable. It's a centrifugal design as opposed to an axial flow, and there are some nuanced differences. And it was just recently FDA approved. So you can see it works like the HeartMate 2. It sits in the LV apex, diverts blood away, and sends it back into the ascending aorta. In their side-to-side comparisons with the HeartMate 2 device, the survival is essentially the same. The same at 1 year as the HeartMate 2. The only thing I could really see is the patient population difference. If you look at the HVAD side on the left, you see there's a larger proportion of INTERMAX 3 patients as opposed to the HeartMate 2, which had a higher component of INTERMAX 1 and 2, which are the sicker patients. Whether that bears out or not, I don't know. You might ask, why is there a difference? I think that what drives a VAD program or a device program is often your transplant program. If you're in a part of the country or in a procurement area that gets organs relatively expediently, you will be more likely to wait on those patients to see if you can bridge them to transplant directly. That's Los Angeles. If you're in a part of the country where a patient may wait 1 year or 2 years and you don't know, you may be more aggressive in VADing those patients, knowing that they're going to have a long wait. And so those are the INTERMAX 3. So I don't think this is gaming the data. I just think this is different patient populations that tend to be looked at in different parts of the country. The one thing that did come up in the early data, though, is a stroke rate, which if you add the hemorrhagic and ischemic types, is about 13%. And they profess to have addressed these issues. That's something we're going to have to look at very carefully now that they're in the commercial phase. There are a lot of advantages, though. It's small. It can be put completely in the pericardial pocket, so you don't need to create these big dissections infracostally. So, and because of their shape, I think one of the most intriguing things is they can potentially be used in off-label indications on the right side. There are no currently implantable RVADs, and this may be one area where we will start to look at these. And I think just in general, competition is good. You don't want a monopoly situation in anything, and devices are included. So this graph just shows you the trends. The red is continuous flow, and you can see how continuous flow really just took off. The blue pulsatile flows are becoming less and less common. The artificial heart was FDA approved in 2004. It's biventricular, pulsatile, it's a pump, and it replaces rather than assists the failing ventricles. And because it's approved only for bridge transplant, they must be transplant candidates. About 1,100 implants worldwide. It provides up to 9.5 liters of flow, and currently it's our only long-term biventricular support option. I think one of the intriguing niche markets for this is in our patients who have transplant heart failure. So these are patients who we put the device in because you remove much of their transplanted heart while they're waiting for a retransplant. There may be implications in having a smoother course because we're coming off the immunosuppression. So I don't know if this will show or not, but this was a video, well, like most times, kind of cursed by technology. This was just going to show you an implantation of the artificial heart. I apologize, it doesn't work. So I think one of the early series, this is Dr. Copeland, Jack Copeland in San Diego, and I really consider him one of the pioneers in this field. And his series of 101 patients, his patients were by and large the sickest patients. 91% of INTERMAX 1. He had 53 days of median support, and his survival to transplant of 68% is almost identical to our BIVAD population that I showed you earlier. The Freedom Driver, this is a busy slide, but essentially this is now under trial, FDA trial, to go from this big blue, what they call big blue, which is like that console I showed you earlier for the PVADs, down to this wearable device, portable device that you can wear as a backpack. So in conclusion, I think MCS is now accepted treatment for our sickest heart failure patients. The PVAD was our workhorse, but now other devices, particularly the Axial Flow HeartMate 2 and potentially the centrifugal pump, the Heartware device, will take more of a center stage. The artificial heart, however, is the only current long-term biventricular option that's FDA approved, and it may have specific utility in our transplant population, and DT trials are currently underway. Thank you.
Thank you, Dr. Kwan.